Hello, this is Troy Thompson, your coding educator for the Specialty Pods. Today I will be going over Radiation Oncology ICD-10 updates for October the 1st, 2016. The Centers for Medicare and Medicaid Services allowed a one-year grace period for unspecified codes during the inaugural year of ICD-10. However, that year is up, and CMS will now expect physicians to document and code with high levels of specificity for conditions that fall within their specialty. Although still allowed, the use of unspecified codes should be rare, and most unspecified codes should fall outside the physician's area of expertise. For all claims with dates of service on or after October the 1st, 2016, you must use the updated ICD-10 codes. If you do not, CMS will reject all claims using the old codes and your practice will not get paid. For commercial payers, some may take longer to update codes. This could result in claim denials and payment delays of a month or more. What can you do to help? Continue to document the highest level of specificity. If something is still probable or suspected, code as a sign or symptom until a definitive diagnosis is made. Document any cause and effect relationships. Keep the problem list and email up to date. Add new diagnoses when appropriate and remove duplicate, conflicting, and incorrect diagnoses when possible. The few changes that we have for neoplasm is going to be the stromal tumor. They have it listed by site, as you can see: esophagus, stomach, small intestines, large intestines, rectum, and other sites. There was also a change to unspecified behavior of the kidney. They have added laterality for that. Additional new codes have been added for elevated prostate-specific antigen, the PSA, rising PSA following treatment for malignant neoplasm of prostate, erectile dysfunction following radiation, interstitial seed or ablative therapy, hormone-sensitive malignancy status, and hormone-resistant malignancy status. We only had one deleted code: neoplasm or unspecified behavior of other genitourinary organs. There are many revised codes, and I just listed a few. So I would ask everyone to just take a quick glance at these, and if you need the additional help in finding the other ones, I'd be happy to assist you. Help us help you. So we would like for you to add comorbidities that may determine your treatment plan and that shows the acuity of the patient. Help us help you. Continue radiation oncology. You all do a very, very good job with being specific for your diagnosis, so just keep on doing that. That's a really good thing. Make a favorites list so that you can easily get to the right code. And once again, don't forget to add those comorbidities. Reach out to your coders or coding educators when needed. Just a few more reminders. For consultations, they must have the 3 R's. That means the request, the reason, and report. Consultations can only be billed out when requested by another physician or appropriate source. And we do not bill consultations for Medicare or Medicaid patients. In order for a service to be considered a consultation, the following criteria must be met and documented in the note. A request for a consultation, along with the need for a consultation, must be documented by the consultant in the patient's medical record and included in the patient's medical record of the requesting practitioner. An opinion is rendered by the consulting practitioner. This should be listed in the medical record in your medical decision making. And also, most important, a written report of the consultant's findings and opinion or recommendation is communicated back to the requesting practitioner. I'm saying the consultations because just by reviewing some of our notes, this is one area that we've been lacking on at certain times. Then just a few more documentation reminders. Don't forget that we need the 3 key components in your note: the history, exam, and medical decision making. We have them listed here. We need a concise statement of the chief complaint. What is the patient coming in for? And just to state a follow-up visit is not good enough. We need the real reason. Follow-up visit is not a good reason that the patient's here. Follow-up for what? We're also, in the history of the present illness, we need to have 4 elements out of the choices: location, quality, severity, duration, timing, context, modifying factors, and associated signs and symptoms. Moving on to the review of systems, it's an inventory of the body systems obtained through a series of questions seeking to identify signs and or symptoms that the patient may be experiencing. Here are a list of those areas. Now, I just want to remind you that an earlier review of system does not need to be re-recorded. Instead, you can correlate the previous review of systems by noting the date and location of the earlier review of systems. So if you did one a week ago, or maybe another provider did it earlier in the day, you can refer to that as long as you have who it was from and the date, and that must be documented in the note. A review of systems may be recorded by an ancillary staff member or on a form, as we do have in some of our clinics, to document that the physician reviewed the information. There must be a notation supplementing or confirming the information recorded by others. For a complete review of systems, you may document all positive or pertinent negative responses and then state all other systems reviewed and are negative. Don't forget that we need the past family and social history, especially on new patients and consults. This can be referenced to a previous note. Include the accurate date, as we said, for the review of systems. The date of that note, because we will go back and we will look for that note. We also need the examination. For the 1995 guidelines, we're looking for 8 or more of the organ systems, and I have them listed below. Medical decision making, this is one of the most important parts of the 3 key components because it reflects the intensity of the cognitive labor performed by the physician. So we need to know what it is that you're doing. The physician must stratify the medical decision making into one of the levels I have listed below: straightforward, low complexity, moderate, or high complexity. Please include the nature and number of the clinical problems, the amount and complexity of the data review. Were there labs? Were there x-rays? Did you need to talk to another provider? And also definitely list the risk of morbidity and mortality of the patient. All 3 of these make up the medical decision making. There was also another area that we wanted to go over today, which is the teaching physicians billing. Minimum teaching physicians billing. So when you have a resident, a fellow working with you, we do need the teaching physicians addendum. The TP personally, it must show that you personally saw the patient and that you participated in the patient's care. I have listed 2 examples of documentation. One states that I saw and evaluated the patient, discussed with the resident, and agree with the resident's finding and plan as documented in the resident's note. So we do need documentation and support of you for the teaching physician's addendum. It becomes unbillable. For time-based documentation, we have to prove that we spent more than 50% of time counseling the patient face-to-face on whatever it is at that time of the visit. I also included examples. For instance, I spent 25 minutes, face-to-face with the patient, more than 50% of the time was spent counseling the patient on, etc. So we have two different examples. And these are some of the examples of what time-based equals out to, and you can freely look at this at your liberty. We will also be scheduling some face-to-face time with me to go over this in further detail. But if you have any questions, please give me a call. Thank you very much, and see you next time.